This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the Division of Neurosurgery at the University of Naples Federico II. It was published in Operative Neurosurgery and focuses on the Endoscopic Endonasal Approach, or EEA, for craniopharyngiomas that have intraventricular extension.
This is a topic that hits home for any skull-based surgeon. Craniopharyngiomas, or CPs, are notoriously difficult, especially when they involve the third ventricle. Historically, we thought of these as the no-man's land for endonasal work, often requiring complex transcranial microsurgery. But this series of 61 patients really challenges that boundary.
Exactly. The authors, Bove and colleagues, reviewed 164 CP cases from 2001 to 2023. Out of those, they identified 61 cases, about 40%, where the tumor either arose in or secondary extended into the ventricular chamber. They used the extended endoscopic endonasal transtuberculum transplanum approach for all of them.
Before we get into the outcomes, let's talk anatomy. The paper identifies 4 main third ventricle growth patterns. Ilara, could you walk us through those?
Of course. The authors categorized them into stalk infundibulum, or SI, infundibulum ventricular chamber, stalk infundibulum ventricular chamber, and purely ventricular chamber. They also highlighted 2 primary anatomical scenarios. In the first scenario, the stalk infundibulum complex is actually enlarged by the CP. Here, the tumor grows inside the infundibulum recess, making the stalk itself a gate to enter the ventricular cavity.
That's a key distinction. If the stalk is already pathological and enlarged, it provides a direct surgical corridor. What about the second scenario?
In the second scenario, the pituitary stalk is intact but displaced, anteriorly, medially, or laterally, by a tumor expanding within the third ventricle. In these cases, the stalk remains a vital reference landmark, and you often see the third ventricle floor bulging beneath it.
Right, and that's where the surgical decision-making becomes critical. Whether you're going suprachiasmatic through the lamina terminalis or subchiasmatic through the infundibulum, the goal is always maximum safe resection while preserving hypothalamic integrity. The paper mentions the 3 to 4 hands technique. For the residents listening, that means 2 experienced surgeons working in tandem, a best-tuned duo, which is essential for managing the complex ergonomics of the third ventricle.
And the results they achieved with that technique are impressive. Gross total resection, or GTR, was obtained in 65.6% of cases.
That's a solid number for intraventricular extension, but they found that GTR wasn't just down to surgical skill, it was influenced by specific factors.
It was. The statistical analysis showed that the extent of resection was significantly influenced by the patient's sex, whether they had received previous treatment, and the tumor location. For instance, recurrent tumors, those with previous treatment, are always more challenging due to scarring and altered planes.
Let's talk about morbidity, because that's the real fear with these high tumors. Hypothalamic, visual, and endocrinological outcomes are what determine the patient's quality of life. What did the data show for vision?
Visual improvement was a major highlight. Postoperatively, 40 patients, that's nearly 77%, saw an improvement in their vision. Only a small fraction remained stable or worsened.
And the hypothalamic. That's usually the most delicate part of the dissection.
The hypothalamic functions actually improved in 20% of cases and remained stable in 45%. They did report new onset hypothalamic disturbances in 16.1% of 31 patients who were monitored for it. While any new deficit is a concern, given the intraventricular location, a 16% rate is quite competitive compared to traditional transcranial routes, which often have higher hypothalamic morbidity.
It speaks to the view from below that the endoscope provides. You're looking directly at the site of origin without retracting the brain or the optic apparatus. However, we have to talk about the Achilles heel of the extended EEA, the CSF leak.
True. In this series, they reported 6 postoperative CSF leaks, which is 9.8%.
About 10%. In the early days of EEA, those numbers were much higher. As techniques for multi-layered reconstruction have evolved, we've seen that drop. Still, 10% in a series of intraventricular tumors, where you are by definition opening the third ventricle, is a manageable but significant risk that we have to discuss with patients preoperatively.
Another point the authors emphasize is the impact of topography. They found that different topographies of intraventricular CPs directly affect the outcomes of resection. Specifically, they distinguish between lesions involving the pituitary stalk and infundibulum, which are lower along the axis, and those occupying the infundibulum third ventricle region, which are higher.
It really comes down to where the tumor is anchored. If it's a pars tuberilis type tumor, it's intimately involved with the ventricular floor. The paper refers to the classification by Kassam and the QST types by Fan et al., but their focus on the SI complex as either a gate or a landmark is very practical for the operating room.
I found it interesting that they concluded that the extension of a craniopharyngioma into the third ventricle does not represent a limit for the endonasal route.
It's a bold statement, but backed by their 61 cases. For a long time, the top-down approach, like the transchoroidal or translamina terminalis, was the default for anything in the third ventricle. But this study shows that the bottom-up approach can provide excellent visualization of the tumor-vessel interface and the hypothalamic walls.
Before we wrap up, let's look at the patient demographics. The mean age was about 52 years, ranging from 10 up to 79. It's a broad range, showing that EEA is viable across different age groups, even in pediatric or elderly patients with these complex tumors.
So if you're a resident or a fellow listening to this, what are the 3 key takeaways?
First, the anatomy of the stalk and fundibulum complex is your roadmap. Determine if it's a gate you're going through or a landmark you're working around. Second, GTR is achievable in over 65% of these cases, but be wary of recurrent cases as the success rate for total resection drops. And third, while visual outcomes are excellent, always have a robust plan for skull-based reconstruction to manage that 10% CSF leak risk.
Well said. This study by Bove and the Naples team reinforces that the boundaries of endoscopic surgery are continuing to expand. The third ventricle is no longer an absolute contraindication for the endonasal route.
It's a great leap forward for minimally invasive skull-based surgery.
That's all for today's episode of the Neurosurgery Hub podcast. Thank you, Dr. Alara, for breaking down the data.
My pleasure. We'll see you in the next episode.
Until then, keep learning and keep operating safely.